Zygomatic complex fracture. Zygomatic complex fracture part 2. Management of zygomatic complex fractures. Historical review. Various authors have given various treatment modalities and techniques for the management of zygomatic complex fractures. Duvernay in 1751 stressed the role of contraction of temporal muscle in realigning the medial displacement of zygomatic arch. Similarly, Ferrier in 1825 attempted to reduce the fracture of zygomatic arch through an incision just above the arch. Dupuytren in 1842 discovered the important relationship of temporal fascia and the muscle as a pathway for the zygomatic arch. Gillies in 1927 emphasized the cosmetic value of placing the incision within the hairline. Stromeyer in 1844 described the percutaneous hook technique. Chemney-Burgard in 1901 discovered the intraorbital digital manipulation technique. Smith and Yanagisawa in 1961 stressed the importance of cosmetic effects of the treatment. Now we come to the timing of surgery. It has been divided into early or late. The surgery performed prior to significant swelling appears, then there is a early surgery has to be done. Late swelling after resolution of significant edema. The edema henceforth appeared on the midface should be resolved if we need to postpone the surgery. If possible, surgery should be performed within 7 to 14 days before significant healing has begun. Stable, non-displaced fractures may be observed weekly for proper healing. General principles of treatment can be divided into no treatment, indirect reduction with no fixation, temporary support, direct fixation, and indirect fixation. Third is the direct reduction and fixation. What is the basic idea between the various principles of the treatment relies upon the degree of manipulation that is required for zygomatic complex fracture cases. In no treatment case with a minimal degree of displacement, which following union are considered unlikely to result any cosmetic deformity, disturbance of vision, persistent paresthesia or impairment of manual movement. That means there won't be any kind of cosmetic deformity, there would not be any kind of disturbance of vision, or a persistent paresthesia would not be present, and even there would not be any kind of impairment of manual movement, and the displacement is minimal. Then in that situations, in that cases, there can be a follow-up of the patient and no treatment can be required in case of zygomatic complex fractures. When we talk regarding the indirect reduction with no fixation, that means only the reduction is going to bring the bone back into its plates and there is no fixation will be required and the bone will heal normally. Includes procedures which do not involve exposure of the fracture sites. Here the fracture sites are not exposed. The principle is to disimpact and reduce the fracture by direct application of an instrument through an indirect approach removed from the fracture line. The techniques which have been developed for this operative approach are based on introduction of an instrument through the temporal fossa, the upper buccal sulcus intraorally, the cheek that is percutaneous, the nose that is transantral, and the eyebrow that is the lateral brow incisions.